2014. As well as that, I've been a GP lead and a clinical commissioner for over 30 years now, and I am currently CCG's clinical lead for dementia services. I think just before we go into the presentation, I recognise that what we've done in Dorset, our dementia services review, looks from the whole of the pathway from prevention through to end of life. What I've tried to do, recognising that that's probably not right for everybody across the whole of the southeast patch, I've tried to make sure that we can demonstrate different parts of the pathway and what we've done in those different parts of the pathways. That includes preventing well, diagnosing well, living well, supporting well, and supporting well in crisis. Now, a lot of this is very operational, and I'm not involved in that, but I'm very grateful to Ranjiv and Kathy from Dorset Healthcare to come along and answer questions after I've done the presentations, if you have them. So first of all, we're on to the why did we do our review. I won't go into this in too much detail because I've timed this presentation and it goes on for too long if I do. But basically, there are a whole range of reasons that were relevant to what was going on in Dorset. We wanted to provide a better service, and there were certain issues that we needed to resolve. An example, I think I'll talk about the comment there about no review in West Dorset services. We have two very different populations in Dorset. One in the east, which is very urban with deprived areas, and one in the west, which is very rural, less deprived areas, but more distance between services, and a whole range of issues related to rurality. We also had two mental health providers, one in the east and the west. We've got two different local authorities, one in the east and the west. And from a historical point of view, that meant, and different PCTs over the years as well, that meant that not only have we got slightly different cultures in the east and the west of our mental health provider, but also historically different funding streams and amounts of funding. So they don't look the same. This was an opportunity for us to make sure we could deliver equitable service across the whole of Dorset. The Memory Support and Advisory Service, I think, is there because another thing we tried to do working with the Alzheimer's Society was to provide a service that provided peri, and post-diagnostic support. It became a little bit embroiled in us trying to hit our DDR, and some of the efforts therefore moved towards that. Post-diagnostic care lost out. We also lost a third of the funding for that service when local authorities could no longer afford to put that money in. And I think basically there were some IT issues and data collection issues that were created because we had an outside provider. So that was something else we needed to look at. Next slide, please, Jane. The process, I think, is quite important because it helped us deliver on those, because it brought everybody involved together and we could have a real out discussion about what we needed to do. We started off making sure we knew what service users thought about our service, patients, carers, etc. And we did an extensive view-seeking exercise, a little bit more detail about that in a minute. We also did a detailed data needs analysis because of the differences that I've already mentioned between what was happening in the east and the west of Dorset. Then we went into, that was all ready and created a direction of travel for what we wanted to do, and sort of began to demonstrate what outcomes we needed. So we went into a modelling option process, and then NHS assurance consultation and implementation. Go to the next slide, please. I won't go into a huge amount of detail, but as you can see, this process we did for the engagement was extensive. This is because we've done some other co-production work, and this was totally co-produced from the beginning to the end. And we knew that if we were going to do the service, do that justice, we needed to make sure we really knew what people thought about the services in terms of what didn't work, what worked, and how we could improve it. and there's more information in this that I'll show you how to access later on, but it was a very important part of the process. It's also true to say that because we're working towards developing a total service from prevention to end of life, and because that pathway interacts with so many different parts of the NHS, local authorities, voluntary sector, etc., and we're moving to an ICS, we wanted to make sure we involved as many stakeholders as possible in the process. So that was another big feature of what we did. Relevant, I think, to all of us now and over the next few years. So next slide, please, Jane. So what we ended up, as you can see from the data analysis information there and the engagement and view-seeking analysis, which was done by Bournemouth University, it created some themes that these themes are basically about us providing a better quality service. So smoother and quicker diagnostic pathway, joined up services across health and social care, support advice and guidance along the whole of the pathway, and that's linked to the dementia care coordinator role that I will go into more detail later on. Information and crisis helpline, improved support for carers, education and training, tackling delayed discharges, improved care in the home, wider options for carers, breaks and respite, and most meet crisis needs and with higher levels of support. So that began us, and all that information was taken into the modelling stage. So if we go on to the next slide, please, Jane. Okay, so we wanted to make sure that everybody who knew about this, because we wanted people to get involved and be as enthusiastic about it as we were. So we had an innovation event where Professor Burns came down and gave an inspirational talk, and also began to tell us about things that were going on in the rest of the country that were innovations, and could we introduce those innovations into what we were doing. So we didn't just want to say we're here to do a little bit here, a little bit there. We wanted to make it clear. We wanted to reevaluate what we were doing, and if there was something we needed to do differently, something we needed to introduce to make this the process better, we wanted and were willing to do it. The design group was basically that whole list of stakeholders having an overview of what we were doing and inputting as we went through the process and checking at the end. The modelling groups, I think, are really quite important here. Recognising we have issues, different services really currently being provided in the East and the West, we set up two modelling groups, one for the East and one for the West. This also allowed access for people at all parts of Dorset to be able to contribute. The modelling groups were consisted of anybody who wanted to come along and could spend 5 afternoons working with us to create the models that we were going to put forward in our business case. It included consultants, nurses from Dorset Healthcare, nurses from the acutes, voluntary sector organisations, carers and supporters, counsellors came along. One of the sessions, we did this whole process in conjunction with the local authorities, and so they ran one of our working groups as well. And the beauty of having that group was that they remained present throughout the whole process. Every meeting they came from, they learnt and learnt from each other, saw different perspectives. And that was really important at the end when we asked them to start making decisions about what proposals that we had come up with, they were prioritised given the funding that we had. We were supposed to do this without any additional money. So we ran these 5 workshops in these 2 sites, and it was, I think, really helpful and beneficial to this process. I think if you're working with quite a diverse group of people and you want to bring them together to come to one and to get some ownership of what you're doing, that's really quite important. Next slide, please. This is just showing that we completed the business case in April 19, but it's taken us 2 years to get to the implementation stage, which was in April of this year. Next slide, please. Was this valuable? Did this work? Did this process benefit us? Well, this is the outcomes of our consultation process. and all those services on the left were new services that we'd introduced. And what you can see from that is that if you look at the strongly agree and tend to agree percentages, in many cases they're over 90%. Now this is people from the local authorities, from the hospitals, GP colleagues, nursing colleagues, service users, voluntary sector organisations, all being asked what they thought about what we come up with. 90% approval is, I can tell you from experience, pretty high. The lowest, I think, being at the bottom there about where we put the specialist beds, and that I think in itself is around about 60%. So yes, it did work, and this agreement, I think, supported us in developing and promoting the service before we implemented it and since. Next slide, please. So what does our pathway look like now? This is our new pathway. The yellowish boxes are all the new services we introduced, and I'll go through them as quickly as is possible in the time I've got. The Dementia Helpline was there to help people when they were thinking about, is this dementia, should I go and see my GP? It's basically a collection of national helplines, Alzheimer's and government, and also local helplines and information. CST is at this early stage because we can now offer, and I'll go into more detail about this later on, CST pre-diagnosis as well as post-diagnosis, and that we feel is supportive of people as they develop their cognitive impairment, and actually also is a place where people can be supported and advised to go forward for a for a diagnosis. So it supports our diagnosis referral rates. We've made some considerable difference to our memory assessment services, which I'll go into more detail in another slide or two. We also wanted to update our dementia directory. Our dementia directory was a large booklet that cost a lot of money to produce and was very popular, but cost a lot of money to produce and was very quickly out of date. So Jane and I are currently looking at how we can change that to something that's more online based and provide carers and people with dementia a booklet that they could store pages from that, download and store pages for their own personal use into, or be given by people they come into contact through the pathway, the dementia care advisors, community mental health teams, etc. We also set up some emotional workshops for carers. Interestingly, the process that we went through told me that these existed and I didn't know before, and that these have been set up independently by a carer support groups, and they said how valuable it was to them. So we thought we ought to commission this. So we have, and Kathy, who is one of the Dorset healthcare representative today, is leading on that, and emailed me the other day to say this is beginning to happen and is going very well. We also set up something called Living Well Dementia Roadshows. Again, something else Kathy led on, which was an idea we picked up from Cornwall. Basically, in order to keep people informed in I think a more face-to-face way, in a more interactive way, we created a scenario where a very large church hall would be hired. We'd ask local providers, and by local I mean small providers within a locality, because these are based around localities, not something that and they're developed to support the locality in supporting itself, if you see what I mean. So so these roadshows would then have these providers doing a very brief 1 or 2 minute presentation, then going back to tables they have positioned around the hall, and then the 80 or so people who came to attend, then going and having a personal contact with the providers, discussing what they did and what they could offer. And those providers included NHS services, local authority services, the police, the ambulance services, a whole range of services, national services, as well as local services. And I think that local nature was very important because we wanted to make sure we included local smaller voluntary sector organisations. Where do we go next? Yeah, community mental health teams. We made sure that all that we did connected into our old age community mental health teams, so that where help was needed from them, the whole process worked well for carers and patients, but also for those supporting people on a day-to-day basis, professionally and non-professionally. We had and this I think goes back to what I was talking about, the difference between the East and the West. We had in-reach services from Dorset Healthcare into our care homes in the East, but not in the West to such an extent. And we decided we needed, because we decided they were valuable, we were going to extend that. We also had a dementia intensive support team in the East, but not fully commissioned and not fully provided in the West. This service is now called the Dementia Intensive Care Support for Dementia, ICS service, and is there to deal with patients who have a diagnosis of dementia, who have a crisis that's very likely to lead to an admission. They go in and they meet the needs of the individual at home. We all know that that's better clinically. It also costs less money, so it's a win-win situation for everybody. The day hospitals are in there because we recognised that our day hospitals could support the ICSD in that work, and it was cheaper to do that than have them admitted to hospital. More of that later. And then we had to look at where we put the beds in Dorset for when they really needed to be admitted. We looked at whether we needed to provide that on 2 sites. In the end, we decided to provide it on 1 site because of workforce issues and because that would allow us to provide better quality care. But we did recognise that we needed to provide a transport service for carers and families of members who had to come a long distance to go and visit their relatives there. We knew that was important to do. So that's a feature of us having those beds in one place. I'm going to talk about the dementia care coordinators in a minute. I think of all the services, they were seen by our patients and carers as the most important, most valuable. So I'll move on to the next slide, please, Jane. Okay, so what does our dementia diagnostic pathway now look like? Well, the GPs were referring into the MSAS, which was our previous service that we'd set up, as I mentioned before, to provide pre, peri, and post-diagnostic support. That was to facilitate and support the referrals into the MAS. The GPs will provide the basic screening test results and the past medical history, drug history, etc. They will then pass the information into the MSAS, who will then do a PHQ-9, a GAD-7, and a functional assessment questionnaire, and then collect other soft information, and then all that referral information will go through into the MAS. This caused problems when we couldn't get all the information we needed from our GPs. It delayed it delayed the transfer, and there were also issues around, as well as other issues around the functionality of that gateway, as we called it, Dementia Gateway, as we called it. So now what we do is the GPs refer directly using e-referrals, or refer directly into one point of access rather than the different community mental health teams and MASs that they were previously using. And that means that when those into one point, and when that referral is received, it's triaged by a clinician who will go back to the GP to collect as much information as they thought they needed before that referral went into the MAS. It's important to point out that although we expect GPs to provide all the information that you'd expect from NICE, we don't want the lack of a B12 or a folate to stop that diagnosis progressing. So we accept that it's better to get the referral done and diagnosis made rather than hold up that process happening because of a lack of 1 or 2 relatively unimportant bits of information. Now, once they go into the MAS, what we've done now is 2 things. I think we've introduced AMPs and ACPs who can, we've got one in the East and one in the West, who can make the diagnosis on behalf of Dorset Healthcare. They have the support of the consultant where that's appropriate. The patient can go and see that the consultant if they wish to. But what it means is that the consultant is not so much involved in diagnosing the non-complex patients, the ones that don't need their specialist knowledge and skills as much as the more complex cases. We did this to speed up two things: to speed up the diagnosis for the more non-complex patients, but also to free up consultant time. We also introduced 2 additional neuropsychologists. They support the consultants who in making the diagnosis in the non-complex cases, and that plus the freed up consultant times mean we expect to be able to speed up the diagnosis for the non-complex patients as well. I've spoken to the neuropsychologists recently, and I think they're providing much more of a service than I thought they were going to. They actually now provide support for the consultant in the complex pathways I've already mentioned. They also support the memory ACPs and AMPs. They also work with our neurology service because of the link between young onset dementia and neurology and Parkinson's related dementia as well. They also work with our LD team, and they also provide education and support wherever it's needed across the pathway. So a really valuable asset, I think. So the patient will eventually receive their diagnosis. We aim for 6 weeks, but more of that later on. And they will get their medication initiated there, and they will usually stay with the MAS if they're starting on medication for about a year, and then everything else transfers over to primary care unless there's a crisis, in which case the community mental health teams will take over. And then within 2 weeks of the diagnosis, working 2 weeks, so 10 working days of the diagnosis being made, they will be seen by our dementia care coordinators. Now, if we go on to the next slide. The Dementia Care Coordination Service took on some of the roles of the old Memory Support and Advisory Service. It is there to, but now the funding that we provided as a CCG for this new service, we didn't actually commission it. It was commissioned as a prime provider by Dorset Healthcare, thus bringing the functions of Dorset Healthcare and the Dorset Dementia Care Coordinators together much more than it had been before. IT issues still occur because although they use the same system as Help and Care, who provide the Dementia Care Coordinator service, it's all on Rio and really doesn't talk to System 1, which we use. But we do make sure that any updates to the care plans are communicated with the GP in a timely way. Their role is to offer guidance and signposting, but they're not a signposting service because the other role is to make sure that the care is that they coordinate the care and make direct links on behalf of the patient and their carer, if needed, to the multidisciplinary teams within PCNs, to social prescribing teams, to frailty teams, to acute hospital liaison teams, and to their delirium teams, as well as any part of the pathway that they need to work with. Every PCN has an assigned dementia care coordinator. The amount of care coordinator they get is determined by the size of that PCN's dementia register. And we've got the representative Nathan here, I saw join us recently, who can talk about how that's working. And I think the caseload is about 201 care coordinator to 250 patients. They're there to support through the whole of the journey, offering low-level support where needed, but very much linked to what the memory assessment service and the community mental health teams are doing. They have clinical supervision from Dorset Healthcare memory nurses. They're expected to create the care plan with the patient, as is in NICE guidance's a recommended care coordinator role, and review it annually or sooner if the patient needs that. And we've got 2 dedicated care coordinators for people with young onset dementia, and that was something that we recognised as a gap as we went through the process of view seeking and modelling. Next slide, please. As I said earlier, the CST role has been hugely expanded. That was after discussion with the Wessex Senate and NHS England, where we went to them and came out of our consultation process. We were going to just do vascular dementia, but now we allow anybody, or we expect anybody who will benefit from cognitive stimulation to be referred into that service via Dorset Healthcare at or soon after dementia, or later on by the community mental health teams, if that seems to be helpful to that individual. 71 courses offering 14 sessions per course over every year. Originally, we were going to spend 3 hours with doing this, but we've discovered that our provider tells us that they can deliver the whole of what they want to do in 2 hours, and it hasn't reduced the patient satisfaction scores. So we're happy that we can do this in 2 hours instead of 3 hours and still get a good positive outcome from that. Again, this is fairly obvious. It's who it's for, which I won't go into. But I think it's also important to say, again, through the process and linking up different voluntary sectors, Age UK, who currently provide the service and Primacare, were, before we commissioned it, from the CCG commissioned it, and are still providing CST services in addition to those we've commissioned as part of the DSR. So we can now also offer top-up sessions where needed, and we'll also see people who haven't been formally diagnosed by them as, or who have a diagnosis of MCI, as well as those with dementia. Next slide, please. As I said earlier, what I've tried to do is to link the different additional services provided to the different parts of the pathway. So in Preventing Well, it's the roadshows and the helplines that we are have done to support that. We monitor this by looking at attendees at roadshows and the numbers using the helplines, and also we're developing a patient and carer questionnaire to make sure it's meeting their needs, and we'll modify it and do something different if it isn't. Diagnosing Well, I've gone through that in some detail. For the next slide, please, Jane. Around Living Well, I've talked about the dementia care coordinators, the carer workshops, the CST program, and as you can see, the outcomes over there about patients feeling giving more choice and control, patients and family and carers that they have an enabling and supportive environment, feel valued and understood, improved psychological well-being for patients and carers, and maintain social functioning and quality of life. All of that contributes to us avoiding crises and avoiding patients needing to go into hospital or into residential care. So very important. Next slide, please. Supporting Well, again, is being provided by primarily by the community mental health team, but also obviously by the care coordinators, CST, etc., where necessary, and provides similar ways of supporting patients and carers in the community, and therefore preventing crises and unnecessary admissions to specialty services, to residential care, or to the acutes. Supporting Well in crisis, I think is something that we needed to improve, and patients wanted to improve. So what we've done now is anybody who feels they're having a crisis, so we allow people to define what their crisis is, can ring into our crisis helpline, which is accessed by our 111 number. The person who receives the call will know what services we currently provide, and we'll do a quick triage and decide whether this is something that can be dealt with by our dementia care coordinators with a bit of advice and guidance and support, whether it's something that might need more medical input, non-urgent medical input, so maybe reviewing medication or dealing with a new psychological or psychiatric situation. But also, if they need to go to the ICSD because they're that close to needing admission, the ICDS can be actioned and go and offer support. I think that means that anybody ringing in with a crisis will get a response that is relevant to their needs. I think it's also what we've been able to do with this since that is add it into what's happening with the urgent care response teams that are now mandatory for CCG, the local authorities, to provide. It also allows us to link it into the work we're doing with the enhanced care and care home work, where dementia is now one of their main work streams. So it's beginning to make much more sense of how we deal with crises, and it's making it more efficient and effective. Next slide, please. So what do we see as the benefits? People will experience a smoother and quicker diagnostic process and receive post-diagnostic support from diagnosis to end of life. People will be supported to live well with dementia and experience less crisis, more choice for people living with dementia through an increased range of community options, including more support for carers, more efficient and cost-effective services, greater compliance with NICE guidance, and reduced inpatient admissions, and cost benefits of somewhere in the region of over 2 million, and substantial return on investment realised across the life of patients with dementia. Now, some of that is clearly aimed at my CCG and ICS colleagues, because we needed to demonstrate this was of value. We did that by making sure they were involved in the process as much as possible. And I will tell you that this worked because we were told we didn't have any additional money. When we presented the business case to the CCG governing body, we said, well, if we have no money, we can make some minor improvements, but not really what the people of Dorset want. If you give us an extra million, we'll do this, and it will introduce a whole range of new services that are really needed and wanted. And if we have those services, it will benefit the ICS by reducing admissions, etc. more. Or you could give us 2 million, and we can do everything anybody could ever think of. In the end, they unanimously agreed to give us an extra £1 million a year. So effectively, they were saving potentially £1 million every year by supporting the DSR. Now, I was asked by Bikram if I could provide evidence that it's working. Well, unfortunately, I can't, and I'll talk a bit about that in a minute. But if you go to the next slide, the £2 million savings we didn't just imagine it. We looked for evidence base for us being able to achieve that. So the dementia coordinator at Living Well savings, evidence from the Alzheimer's Society work with their dementia advisors showing some savings, evidence from dementia roadshows from Cornwall and the carer workshops, etc. So we can evidence that. The evidence is all in the business case, and you look into that. 10% reductions in dementia specialist inpatient beds expanding the ICSD service is calculated in work we've done in Dorset. The Dorset Healthcare have done at nearly 600,000. Day hospital provision instead of dementia specialists in inpatient admissions, again supporting the ICSD and avoiding admissions, potentially nearly another $1 million. 37% reduction in inappropriate admissions to the acute hospitals, again emphasising the benefits to the whole system by supporting the DSR, and a 10% reduction in section 117s. That's a particular thing in Dorset. We have a very high 117 cost, and obviously if they're admitted to a nursing home for care, we need to pay for that, or part of it anyway, and therefore if it avoids admissions into care homes, it doesn't only save the local authorities money, but it also saves the CCG some money. Next slide, please. Something I think we need to point out, that all of our costings and demand capacity work was done pre-COVID, and COVID has had a significant effect. We found that our referrals into the MAS have gone up by about 50% and maintained at that level since March of this year. We're not sure why that is. We think it may be because I spent a lot of time, and Jane and etc. On all the team promoting the service and telling people how good it was going to be, which we hope it will be. We also thought that easing of lockdown meant that people to come forward for a diagnosis. we thought that isolation factors may have caused a decline in physical and mental well-being of people who may be very early in their dementia process, but were coming forward earlier because of the additional strains physically and mentally. We also wondered if people were families were now seeing their elderly relatives being able to visit them and noticing their decline and noticing changes within their living situation, and that might have provoked it. I think there's also a very likely probability that there are the direct effect of COVID to the neurologic nervous system and vascular system of people in that age group is probably also creating another cause for dementia, i.e. COVID. We've also had to make some other adaptations to the pathway, using much more digital work through diagnosis, through our roadshows. How can we deliver those online rather than face-to-face? How we deliver our CST. So a whole range of adjustments we've had to make because of it, which we're happy to share with you if you want to learn more about that. And then the next slide. We're developing an evaluation plan. We think that's important, but it won't be available till at the earliest about March or maybe a bit later. Next slide. Today we've got, if you want to ask us questions, the contact details are on the slides. Myself, Jane, Ranjiv, who's the clinical lead for the MAS services, Kathy, who's the lead for the MAS services, there's a Nathan who comes from Dorset Healthcare, and Gary Mason, who I don't think is here, but is the lead for our CST services. And the last slide, Debbie, I'm sorry, is I've tried to shrink a 123-page business case down to 30 minutes. It's really been difficult. I haven't mentioned all these other papers that you can access from our webpage or directly off these slides. So if you want to understand a bit more about our view seeking, the way we did view seeking, data needed analysis, etc., it's all available on there. That's it, Debbie, sorry.
No, that's brilliant, Paul, and thanks for making all that information available for people so they can sort of follow up later. That's yeah, it's a big piece of work there and some great achievements there, I think. I have one question just to open it up with, and so you said demand's increased. Did you told me a figure before by how much demand had increased?
About 50%.
And how are you managing that through the triage and prioritising people?
Yeah, well, we had a backlog as well, and we used the funding that was provided to support the services. That's all gone into our diagnostic pathway. Kathy and Ranjiv, if you'd like to add to that, because that's your operational piece.
It is. You're right. So I think with the backlog, we were really surprised that we would get so many people referred to the services over and above what was expected. And obviously, although the Dementia Service Review did give us some finance for additional staff, obviously there was a recruitment time for that process and also an induction time for that process as well. So we weren't at full capacity anyway. We had recruited the staff, but it was waiting for them to actually get working, really. What we did do, we had to go to an agency to get a worker in to do the initial assessments. We also, because we were struggling trying to get good bank workers to do the assessments, we noticed that other memory assessment clinics had actually put adverts out for assistant psychologists to do the initial assessments. So we did that as well. So we have 3. We've got 2 we've got 1 that's already started, and they'll be fixed term until the end of the financial year, and we've got 1 starting next week and 1 at the beginning of January, and that will be purely to help support that backlog. We also have a locum medic, because obviously what comes in through the front door needs to come out the back door. So we have to have the diagnostic part of the pathway as efficient as we can be, because that was the whole thing about the dementia service review. It was about less duplication, streamlining what you'd got, managing your process more timely, and for patients to know who's doing what within that pathway. So as I said, we have a locum medic who also is working with us full time. So that's really helped with the time that people are waiting for a diagnosis. So it's really tricky, Debbie, managing a new pathway in the middle of a global pandemic anyway, and trying to work that out, because like Paul said, we had to work a bit more, we had to be a bit more creatively in how we deliver services. So we use virtual technology. We use Attend Anywhere, which is a bit like Zoom, but it's the one that we use for clinical work. And also what we have done is use telephone call assessments for those that can do that for the first part of the information gathering, and then it's a shorter home visit for the cognitive testing. So yeah, it's, we went to MSNAP, we went to lots of the MSNAP conferences, webinars that they put on to try and work out how are other MAS clinics managing during the pandemic, but also knowing that we were changing the pathway in April as well.
Thank you.
So
I'd like to open it to others to ask some questions. Have we got any questions for Paul and team?
Yeah, I have a question, if that's okay. So really interested in the dementia care coordinators, I think they're referred to, which you was discussing, and we've got dementia care advisors, and I'm wondering if we're talking about the same thing, because what's come up in our engagement sessions, we've been doing a lot of engagement sessions, particularly in Windrusk and Maidenhead, and I know we've got 5 based across Frimley. They're also doing the same sort of thing, and there's been 2 priorities that have come out of those engagement sessions that we had, and one's being single point of access for carers support, and another being the care coordination side of things. And I'm wondering, is there a difference between the dementia care advisors and the dementia coordinators? Are we referring to them as one and the same thing, or have you upskilled your dementia care advisors to almost do that coordination as well?
Okay, I'll answer that one, but I'll bring Nathan into that one, Ryan. So the MAS clinic is registered professionals. So we've got nurses, OT, neuropsychologists within the MAS, the diagnostic, the assessment, diagnostic and treatment service. The part of the pathway that Paul referred to for the dementia coordinators, that was what was contracted out to Help and Care, which is a local charity in Bournemouth, and they have a lot of different services under their Help and Care umbrella, which is really helpful for us. But they provide the post-diagnostic care for people with dementia. So when the person is diagnosed by, say, Dr. Jaswell, who's with us today, we will actually refer on for a dementia coordinator. So they don't sit within MAS, but we work closely together. What they do, Ryan, is have access to, we use Rio. I don't know if you use Rio, but they have access to Rio, which means that's really helpful with the communication, because that's the issue sometimes when you work with the third sector, that, everybody's getting a phone call about the same thing, and nobody knows who's doing anything, whereas the dementia coordinator has access to the system that the MAS nurses use to Rio. So that means everybody knows what everybody else is doing, which really helps with those phone calls from a distressed relative, and you're trying, you're calling everybody to try and support them, and it's already been done. But Nathan is here, and Nathan's the dementia coordinator lead, so I'm sure he'll answer any more questions there.
If it helps, we just had sorry, hi everybody, sorry I was late earlier. So I'm also suffering with a cold as well, sorry. We had a case yesterday just to show how this works, and the coordination is one of my staff members called me up with a safeguarding where a person with dementia had grabbed hold of his wife. It wasn't particularly being physically abusive, but there was a knife involved, and they started cutting up items around the room. It was a very intimidating situation. So we were able to have a look on Rio, and we could already see that CMHT had been involved in November, and they'd done an investigation. They'd helped out at that point, and they felt it was okay. Without Rio, we would not have been able to see that. So instantly we raised a safeguarding to the local authority, but we're also able to go straight back through to the community mental health team to say, hi, you saw this person, this is the situation now, it's escalated again, would you be able to come back involved? So it's just having those link ups that we can do right across the board. We don't just stop there, obviously. People try and explain to me what my guys do, and it's it's massive. So right from just informing a person about dementia and the prognosis and what can happen. Obviously, there's so many different types of dementia that we're dealing with. We do the carer support as well, all involved. So I was explaining the other day, we've taken in over 1,300 referrals already in 8 months. So we've absolutely, it's gone crazy for us. We're managing, but it is extremely busy. But each one of those referrals could easily be speaking to 2, 3, 4 different people. You may be making 5 different phone calls to support that person with various referrals, calling them back, checking in they're okay. As Paul said earlier, we may need to check in on people sooner than 12 months. When, if they've no support network around them, we're calling them back sooner. It's a massive job role we've taken on. We've done it for quite a while, but not to this same level and the detail we're putting into it now.
Just quickly, you did work for the Alzheimer's Society, didn't you? And now as more in a dementia advisor role, and now you work as a dementia care coordinator. What do you think the big differences have been?
I'm going to say straight away, COVID has absolutely caused the massive amount of disruption it can, especially to carers. Carer burnout has become significant across Dorset, and I'm sure it's exactly the same across the UK. A lot of our work, I'm going to say there's probably a split of maybe 60-40, where we're actually dealing more with carers than the person with dementia. A couple of reasons. Sometimes the person with dementia really may not have wanted to engage with it and almost denied that they had dementia, or they really weren't in a position where they could engage with us themselves. So a lot of it was carer support, which is fair enough. But right now it's probably gone up to sort of 80%, where carers are coming back to us on a consistent basis now saying, how do I deal with this situation? What do we do with this? I'm at the end of my tether. And we've had those phone calls of people on the phone crying their eyes out, not knowing where to turn next. And we've just, even if it is just that listening ear, and providing practical support and giving them places where they can go, even if it's just information, that's what we're there to source all that for them. So the carer work we do now is a lot more detailed, and it's very complicated situations we're now involved with as well. It's a lot more complex than it ever used to be. It used to be very simple, give the information about dementia, few bits about benefits, and just be there for them. Now our safeguardings have gone through the roof. I'll say they've gone up a lot since before COVID. It's a much more sensitive and difficult subject at the minute.
And I guess it's important to be clear to the group, isn't it, that your service, the dementia coordinator, is for anybody within Dorset that's got a diagnosis of dementia. It's not just for people that have come through the memory assessment service.
No, it's for anybody.
It's for anybody.
I think the learning for us as well is, you've got a dementia coordinator per PCN. I think we can learn from that. And I don't want to take up too much time, but yeah, thank you for that. It's really helpful. Thank you for the presentation, General.
The job description is actually in the full business case, and I'm sure if you wanted to contact Nathan and look at what he does, he hasn't told you half of what he does, I can tell you.
Oh yes, please. If we could get a copy of that, that'd be amazing.
I think was your email address in the slide pack?
It was, yeah.
Yeah. So if you send us the slide pack, Jane, we'll forward it to everybody. Katie,
Yeah,
wanted
drop me
to
an
come
email.
to you.
Yeah. Sorry.
Great. Thank you, Nathan. Thank you.
It's a really inspirational talk and service. So thanks very much. It's lots of much food for thought for Ryan and I, and I'm sure we'll take it back to our both our places and our CCG as well. Just a couple of questions, and I had to take a call, so this may have been covered, but I'm just wondering, the first thing was about the Dementia Helpline, about what the hours of operation are, what the level of staffing is on that. And then secondly, are you using primary care to sort of make the diagnosis? Do you have a GP diagnosis service, or is it all sort of in secondary care with psychiatry-based diagnostics?
The DSR did, the service users and the whole team didn't want primary care diagnosis. It's something I've tried to promote for some time, but it's not there yet. We have tried to see if that will work. Randy can talk a little bit about that, but it's not something we generally do, and not something that the DSR said it wanted to happen.
Thank you.
It's the first thing to say. But Kathy, you might want to talk about the helpline, because I'm
So the memory assessment service are 9 to 5, Monday to Friday. The connection service, their hours, I can't quite remember now, to be quite honest. I think it's till 10. So they do outside of hours as well.
Sorry, the connection service is the Dementia Helpline, is it?
Yes, yeah,
That's
it's a helpline.
9 in the morning till 10 at night, did you say?
Yes, and I think, but they can link in with the crisis team and the home treatment team, who are 24/7.
Right. Okay. Thank you.
Yeah.
And what sort of banding of staff are manning that? And how many staff do you have in it?
They have a team lead. So the team lead is a band 7, and they have band 3s working.
Yeah, thank you for that. Do you know how many you'd have on a shift?
I'd have to find out for you, Katie, because I don't work in that particular service, but I'll find out from the lead. That's a little bit more information. We have done quite a lot of training with the connection service, because we felt that was really important because of the type of calls that possibly they would be getting. So we have regular, it was monthly. Obviously, COVID's thrown a lot of things out of the window for things like face-to-face training. So there's been a lot of virtual, a lot of information giving to the connections team. To be honest with you, they've always taken calls about people with dementia, carers that are concerned. Sometimes it's very simple calls like the carer's not turned up today. And I asked them recently, do you have many calls that you need to action? And they don't. Quite often it will be about carers not turning up, or it will be about somebody running out of medication or losing medication.
Okay, thank you. And one last thing to mind actually was just about the PCN prevalence. Is it fairly uniform across Dorset? Because we've got issues in our area where we've got some with much higher prevalence and some with lower. So we may not need one per PCN. I just wondered, have you sort of factored that in, or have you just sort of allocated one dementia care coordinator to each PCN, or has there been some flexibility on that?
As I said earlier, that the amount of the whole time equivalent that is allocated to each PSN is dependent upon the size of their dementia register.
Right, so sorry, I missed that bit.
You will get more time from your dementia care coordinator if you've got a larger dementia register than those with the smaller. The caseload is I think about 250 per care coordinator. I don't know if Nathan wants to comment on that.
Yeah, we're probably going to end up surpassing that at some point. We've looked at other avenues to make sure we can contain the work, so we've done that. As regards PCNs, yes, we've got one per PCN, but I don't know how you work within PCNs or other people do. I know my other colleagues are very embedded on the other side of our contracts within help and care, and take a lot of direction and referrals straight from GPs. We don't quite work like that. We still have to go through a single point of access, a triage, to get those referrals. But what we like to do is have them as a point of contact in network meetings, and for them to have that local knowledge around that PCN. So, you know, there's all right to say we can get things across Dorset. Sometimes it is literally what they know in that area is even more vital. So we've kept it as clean and cut as we can. But some of the PCNs will maybe share them. So one is not very big, maybe fairly quiet. So they'll do most of their work in that PCN, but they'll also share it with another one who's got a much busier PCN. And we just work it on the referrals that come through.
Sorry, Maggie, did you want to comment on the GP referral bit? Because
Can I just take a question first and we'll come back to that? Because I think Kathy's been waiting quite patiently. In fact, she's managed to get 2 hands up. I don't know how you managed to do that.
I don't know. Well, I don't know either. Sorry. Hi to everyone. I'm Kathy Salmon. I'm the strategic nurse lead for care homes and frailty at Surrey and Borders, working across the whole Surrey and North East Hampshire. I'm also doing a separate piece of work around transformation in the mid-Surrey area, around Surrey Downs and East Surrey CMHT. And really, it's a question to Kathy about managing your demand and capacity through to your MAS service. Like everywhere else, I don't think we're going to be any different to everywhere else in the country. We've seen a dramatic increase in referrals. So the Mid-Surrey team is our largest team in the trust, much bigger than our adult mental health services, which is always a bit of a surprise when I talk to my adult colleagues. And on average, they get between 40 and 50 referrals a week into the service. And one of the biggest issues we've got now is about managing that demand and capacity and looking at people's caseloads. You know, when you've got CPNs with caseloads of 80 plus, it's not sustainable. And so we have looked at different ways of managing the demand and capacity. And one of the things we've done in Surrey is, which won't help around the diagnostics, but might help with more of the ongoing support, because at the moment in Surrey, within Surrey Heartlands, it's all secondary care that makes the diagnosis for dementia. We haven't got any GPs at the moment who are doing that. And that's been not saying they shouldn't or couldn't, but again, like everywhere else, it's about negotiation, it's about training. So that's another, I think that's a whole meeting another day. But one of the things we've set up is advice and guidance for GPs via the referral system. And each CMHT now has got, they've got direct access into a consultant psychiatrist, so they can ask a question rather than make a referral. So perhaps for somebody who already diagnosed with the dementia, and it might be around management or medication or issues that traditionally would have come as a referral. But we've also, in the last 2 weeks, launched advice and guidance for care homes to support care homes. So in the Surrey Downs area, we've got 3,500 care home beds in that area, which again puts a lot of pressure on already existingly stretched resources. So what we've done is set up an advice and guidance for care homes. So instead of making a referral, they can email in a question about managing complex behaviour. And we've got senior practitioners manning it who will respond to that person within 72 hours and offer support, whether they need advice on care plans, covert medication, or signpost them to advice and guidance through the consultant. So again, it's about managing that demand and capacity. But my concern is also around the waiting list and trying to get people diagnosed from assessment, from referral through to assessment in 6 weeks, which at the moment we cannot meet with the demand and capacity we're seeing at this moment in time. And have you got any pearls of wisdom to offer me about that?
Do you know, no, I think, as I said earlier, you know, it was a real shock to us, the amount of people that we were getting referred, and we have had to change the way that we do things, Kathy, within our own service. So we've actually got a band 6 nurse that does all our triage that comes in to the service. We have to have another band 6 nurse who does the duty work. So that's actually taken 2 away from the assessment work.
Exactly the same issues.
Yeah.
Exactly the same issues.
And I've got friends in different, you know, I've got colleagues that I've met over the years in different MAS clinics. And at least, you know, whilst I was panicking about the amount of referrals and the time that people were waiting, actually there's some comfort in knowing that nationally you're the same as everywhere else. whilst you don't want people to it. And again, that was where we tried really hard to think, how are we going to be creative and do this, which is where we, you know, had to do the assistant psychologist, because the bank nurses, as you know,
those as well. We've got exactly the same. We've done assistant psychologists. We have got one of our teams that all of the CPM posts at the moment are currently agency staff. We haven't got a substantive nurse. So it is about thinking differently, and that's why we started the advice and guidance. I've got to say the care home one is taking off far better than the GP one, even though GPs have had access to advice and guidance to other disciplines for many years. It's not a new service. For mental health, we're struggling to get them to use it, but the care home one is really starting to help us manage some of our demand capacity around, especially when you've got, like I say, 3,500 beds in one area.
And we've got
that's a small district general.
And I think what we tried to do as well is we tried to put our medics into GP surgeries for the diagnostic appointments, and with the view to building up relationships within the, you know, with the GPs. And maybe Ranjit can just talk about the Highcliffe practice, Ranjit.
Yeah, I think this is pre-COVID, and I was working very closely with this quite a big GP practice, and working how we can reduce the referrals to the memory service, and make it more efficient, that the GPs can, I can facilitate and help GPs to make the diagnosis where necessary, and also whether there was an element of prescription or prescribing which could be assisted with. So it was working reasonably okay, because there were some ANPs involved from the GP practice who were doing the initial assessments for the Highcliffe Medical Centre, and then the GP will have a look at it and decide whether they can make the diagnosis with some help, or they can directly kind of pass it on to us if it's more complex. I think, unfortunately, because of the COVID pandemic, that piece of work has kind of fallen by the wayside a little bit. I'm sure we'll come back to it once things are a bit more settled. But I think it was one of the things which we wanted, and Paul also spoke about that previously. We wanted to replicate in other areas and in other kind of practices. And I think what we need, obviously, I'm happy to help, other medics are happy to help. We do need GPs who are happy to do that, because there is a significant amount of reluctance on GPs to make the diagnosis themselves. So I think it answers briefly your question as well as Katie's question about working with the GPs.
Definitely. Thank you.
Do we have any further questions, or do you want to say anything else about GP referral? Because I cut you off there. Do you want to say anything else?
No. That's like I say. I think we're no different to anywhere else, and I'm sure colleagues from other counties will say exactly the same. It's around the demand and capacity, but I personally think as services, we do now need to think and work differently, because it's not just about the demand and capacity of referrals. It's about the actual recruitment of staff, retention of staff. We have to work differently and think outside the box now to deliver a more effective service.
I think it's also important. I think, Ranjit, when you were working with Rav, what I saw happening was that just that communication, face-to-face communication, that facilitated the process, and I think the understanding and trust that was developed by doing that has been important, and something, as Ranjit says, does require two willing parties to make that happen. But at the same time, I think if you can work to develop that, it's really benefits everybody, particularly the patients, I think.
Thank you. Do you have any other hands? Any other questions? Let's just see if there's any questions in the chat. I don't think so. Fantastic. Do you want to say anything else, Dorset crew?
I'm just going to say we recognise that this is a very constricted time. There's a lot of stuff that we've done that we haven't been able to highlight. If people want to ask us, I hope that the team will be happy to we receive.
Perfectly happy for people to contact you direct,
Yeah.
Paul and team. Perfectly happy. We're all about getting things moving in dementia services, so we're quite happy. So thank you very much for the presentation. You're welcome to stay, but you've probably heard some of the stuff we're going to say already. So up to you. But thank you very much. Thank you.
Thank you.
Thank you.
You're welcome.
Thanks. Bye.
Okay. Stop the recording now, Lou. Brilliant.
No.